Welcome to the Kanski lecture series, and this is chapter 11, glaucoma part 9. And in this part we are going to discuss about the neovascular glaucoma. So let's get started. So what is the neovascular glaucoma? It means that the new vessels has been formed and which is causing the increase in the intraocular pressure. So, what is the pathogenesis of the neovascular glaucoma? Neovascular glaucoma occur as a result of the aggressive iris neovascularization, which is known as rubeosis iridis, which leads to the progressive angle closure and rapid glaucomatous atrophy. The common etiological factor is severe diffuse and chronic retinal ischemia. It is postulated that hypoxic retinal tissue produces angiogenic factor in an attempt to revascularize the hypoxic area. The most important of these is VEGF. So basically what is happening is that iris is having a neovascularization. Why? Because there is when the retina is ischemic, like in the case of a diabetic retinopathy, CRVO, and other cases of ischemic retinopathy, there are the angiogenic factors that have been produced, which is known as VEGF. So when these are produced, this causes neovascularization everywhere, on the disc, elsewhere in the retina, and it also causes the neovascularization in the iris as well. So these iris vessels causes the membrane formation, fibrovascular membrane formation at the angle, and it causes the when it forms the membrane, it is caused the open angle glaucoma, and when it's get contracted, it causes the angle closure glaucoma. So, what are the causes of the neovascular glaucoma? Ischemic central retinal vein occlusion accounts for 35 to 50% of the cases. A visual acuity of less than 6 by 60, a relative afferent pupillary defect, and extensive peripheral retinal capillary non-perfusion on fluorescent angiography are useful predictive of the risk of subsequent neovascular glaucoma. Glaucoma typically occurs 3 months after the occlusive event. 100-day glaucoma, but intervals from 4 weeks to 2 years have been documented. So most common is the CRVO, and it is one of the most common cause for the neovascular glaucoma, and it usually occurs 100 days after the glaucoma. It is after the attack, so it is known as a 100-day glaucoma, but sometimes the interval is also reported to be 4 weeks to 2 years. Next is a diabetes mellitus account for a smaller proportion, whereas the diabetes was the cause in 30% of the cases in the past. This has been dropped to 10 to 15% of the cases in communities where yearly screening of the diabetic retinopathy occurs. The risk of glaucoma is decreased by the pan-retinal photocoagulation and by anti-VEGF treatment. Pars plana vitrectomy in diabetes may precipitate neovascular glaucoma 7% overall in her last studies, especially if a neovascularization is present preoperatively. So basically, second most common cause is a diabetic retinopathy. Now it cases have been decreased. Why? Because of the new treatment modalities such as PRP and anti-VEGF treatment. Arterial retinal vascular diseases such as central retinal artery occlusion and ocular ischemic syndrome are less common cause. Miscellaneous causes include intraocular tumors, long-standing retinal detachment, and chronic intraocular inflammation. So one of the is like rubiotic is being its cause for the iris neovascularization. R means CRVO, U means for uveitis, B means for detachment, E's for Eales disease, ocular tumor, inflammation, trauma. So these are all the cases of the uh, rubeosis iridis. Next is a clinical feature. Symptoms vary from none to severe pain, decreased vision, redness, and photophobia. Cornea, if elevated IOP, particularly when substantial and acute, leads to corneal edema. So whenever there is a corneal elevation, IOP elevation, there will be the corneal edema. Why? Because the endothelium is unable to pump the fluid out of from the stroma, so that is why there will be the corneal edema. IOPB may be normal in early disease process but is frequently extremely high later on. The anterior segment will often be congested once progress to elevated IOP has occurred. In advanced disease, hypotony may supervene. So low IOP then raised IOP, then hypotony ensues. Anterior chamber, flare cells and posterior synechies may be present depending on the severity and the stage. Presentation is sometimes with the anterior chamber hemorrhage. Why? Because the that the new vessels are being leaking, so there can be the flare, there can be the cells, and there can be the posterior synechy as well due to inflammation. Pupillary margin. Subtle vessels at the pupillary margin are often an early sign but may be missed unless the iris is examined carefully under high magnification. Diagnosis at this stage is likely to substantially improve the prognosis. Iris surface. New vessels grow radially over the surface of the iris toward the angle. So it grows radially on the iris surface, sometimes joining dilated blood vessels at the corona artery. At this stage, the IOP may still be normal, but when elevation can occur fairly acutely. So let's see figure 11.45. It is showing the neovascular glaucoma. A is showing rubiosis and angle closure by peripheral anterior synechy. B is showing progressive cynical angle closure. C is showing mild rubiosis iridus at the pupillary margin. D is showing the severe rubiosis iridus. E is showing hyphema. F is showing the blind eye, showing dilated pupil, ectropion, UVI, and cataract in the presence of a tube. So basically, ectropion UVI is that there is a ectrom UVI is basically the iris pigment epithelium layer has been formed in the anterior surface of the stroma. Next is that what will you see in the gonioscopy. It has been told earlier in the chapter that basically neovascular glaucoma can be open angle and closed angle as well. So angle neovascularization may be commonly occur without other sign, particularly after CRV, and it is important to perform careful non-mydriatic gonioscopy in an eyes with the at risk. Early sign may be very subtle even in the presence of the moderate IOP elevation. Neovascular tissue proliferation across the face of the angle, forming an obstructing neovascular membrane, fibrovascular membrane that subsequently contract to close the angle. So whenever there is a neovascular membrane, it is not closing the angle, but when there is a anterior synechy that has been formed, it will close the angle. The angle closes circumferentially, leading to a very high IOP, severe visual impairment, congestion of the globe, and pain. The visual prognosis is generally poor by at this stage, but aggressive management can achieve comfort and retain useful sight in some cases. Cataract is common once ischemia is established. Posterior segment signs corresponding to etiology glaucomatous optic neuropathy may be present. So, what will you do? Investigation. So, fluorescent angiography may be helpful in confirming etiology and delineating ischemia. B scan ultrasonography will help to exclude the potential causes such as RD and tumor where the posterior segment view is impaired. Anterior segment OCT has been proposed to as a tool for angle assessment. So you should know about what is causing the neovascular glaucoma. If the posterior segment is not visible, you can do ultrasound, so you can see that if there is any tumor or there kind of any detachment, and you can do fluorescent angiography in a case of a CRVO and other diseases. Why? Because in a case of a neovascular glaucoma, you have to treat the cause as well. You have to treat the cause as well instead of just going for the neovascular glaucoma. It is treatment. It is critically to address the cause of neovascularization as well as the elevated IOP. Appropriate management of the systemic disease is also of a key importance in order to reduce the risk to the fellow eye and to reduce the risk of stroke and to prolong life expectancy. Factors that predict a poor visual outcome include young age, visual acuity less than 6 by 60, and IOP greater than 35 millimeter mercury on presentation. So these are the poor prognostic factors: young age, visual acuity less than 6 by 60, and IOP greater than 35 millimeter mercury. Review. Frequent review during high risk period is critical. The first few months following an ischemic CRVO and the first few weeks following the diabetic vitrectomy. So you have to basically review the patient every month in a case of ischemic CRVO and in a case of diabetic vitrectomy after a few weeks. Medical treatment of an elevated IOP is as for POG, but myotics should be avoided. So it is one of the case in which we are going to give the atropine mydriatics instead of myotics. Why? To reduce the formation of the synechies. Topical atropine 1% twice daily with resist synechy formation and increases the outflow of the aqueous through the uveoscleral route. Topical steroids are beneficial in the acute state. Topical epiclonidine and oral acetazolamide may be useful temporizing measure. Acetazolamide can be associated with renal dysfunction in diabetes, especially type 1, and should be used in caution with these patients. Next is the pan-retinal photocoagulation. PRP is usually effective in inducing regression of neovascularization and if performed early, preventing progression to glaucoma. It will not reverse an established fibrovascular membrane. The typing of the CR view is discussed in chapter 13. If the retinal view is poor, indirect ophthalmoscopic application may provide better access if necessary, performed in an operating room with iris hook to open a pupil caused by posterior synecdoche. Transscleral cryotherapy may be used in eyes with opaque media or as an adjunct for increasing peripheral retinal coverage. So when you do PRP, so PRP is basically done to reduce the ischemia, retinal ischemia. It will reduce the retinal ischemia and it will causes the less production of the angiogenic factors. So in a case of like a CRVO, we do PRP as soon as there is a formation of the new vessels at the retina. So in that case, we do PRP as soon as possible when there are new vessels. And basically, you can also, if the retina view is poor due to posterior synecdoche, you can take the patient to the operating room and use the iris hook and then apply the laser. And if still not visible, you can do the transscleral cryotherapy. Next is the intraocular VEGF inhibitors. Bevacizumab Avastin at a dose of a 1.25 milligram in 0.05 ml is an effective adjunctive measure while waiting for PRP to take effect, particularly if a fibrovascular angle closure has not yet supervened and usually lead to rapid pain relief. So PRP takes some times like 4 weeks to become effective. So you can for the time being give the intraocular VEGF for the neovascularization. Intracameral AC injection is an alternative to the intravitreal route. The duration of the control from single injection is limited and most patients require ongoing injection. In patients with ischemic CRVO treated in this manner, the onset of NVG can be delayed up to 18 months. There is a risk of a central retinal artery occlusion in a patient with ocular ischemic syndrome. So, whenever the patient with a CRVO is undergoing anti-VEGF ischemic CRVO, so what happens is that we can the glaucoma rate is reduced by 18 months, neovascular glaucoma. Retinal detachment repair should be performed once the IOP is controlled, particularly if there is a tractional retinal detachment around the macula. So you have to treat the cause. If there is a retinal detachment in the posterior segment, then you should treat the retinal detachment through surgery. Ciliary body ablation, cyclodiode should be considered if medical IOP control is not possible. These have conventionally been used only in eyes with poor visual outcome, but can be employed if there is a reasonable vision in order to prevent severe glaucomatous damage occurring while neovascularization is brought under control. Lowering a substantially raised IOP generally improves comfort and clearing corneal edema and may facilitate an adequate retinal view for PRP. Care should be taken not to use excessive treatment which can lead to hypotony. Endoscopic cyclophotocoagulation is an alternative to transscleral treatment. So, what is ciliary body ablation? So, there is a laser called cyclodiode. When it is applied, so for example, this is cornea and this is sclera. So, on the transscleral, through the sclera, a probe is being rotated on the sclera, and the ciliary body is basically present almost 4 millimeter behind the limbus. So this is being ablated. So what will the ablation of the ciliary body will cause? You know that a ciliary body usually produces aqueous humor. So when the ciliary body is being ablated and it is burned out, so there will be less aqueous humor production, or new, so it will lead to the decrease in IOP, and it is usually done as a last stage and when there is a very poor visual potential. But it's like it can also cause hypotony. Filtration surgery may be considered if visual acuity is hand movement or better. Options include artificial filtering shunts, glaucoma drainage devices, and trabeculectomy with mini shunt implantation, and adjunctive myotomycin C, and post-operative subconjunctival 5-fluorouracil. Active neovascularization and inflammation should be controlled preoperatively, including preoperative anti-VEGF treatment to improve the chances of surgical success. Even with treatment, there is a relatively high risk of hypotony. Post-operative anti-inflammatory treatment should be aggressive and may include systemic steroid. So basically, you have to treat first in a case of how you treat the glaucoma, basically in a neovascularization. First, you have to treat the neovascular. If you are planning for surgery, like filtering surgery, you have to treat the neovascularization first, or inflammation, before undergoing for surgery. Because if you just do the surgery in case of a neovascular glaucoma, there will be so much bleeding that the operation will be unable to be performed. So first you treat it with the anti-VEGF, and when the it is controlled, then you go for the surgery like filtering shunt surgery. You can go trabeculectomy with antimetabolites. Pars plana vitrectomy with pre-operative and per-operative endolaser at an early stage may improve the prognosis in eyes with vitreous hemorrhage, especially in CRV. Or pre-operative intravitreal anti-VEGF may be benefit. Retrobulbar alcohol injection is useful in relieving pain but may cause permanent tossing and does not relieve congestion. Enucleation or evisceration may be considered if all else fails. So basically, these are done when there is no visual potential, and these are just done just to relieve the patient from the pain because of the glaucoma. The underlying cause of the neovascular glaucoma need to be determined and treated in order to reduce the risk of visual loss in the following fellow eye and to increase the life expectancy. So, what is the prognosis of a patient with a neovascular glaucoma? Patient expectation need to be realistic, and the best outcome is often a blind but comfortable eye. The prevalence of the blindness in the affected eye varies from 25 to 50% depending on the length of a follow-up. Life expectancy is reduced significantly in these patients, approximately 50% of the expected lifespan. A good presenting visual acuity in the affected eye is the useful predictor for longer life expectancy. Basically, these eyes have a very poor prognosis, and they are more likely to become blind by 25 to 50%. And also the life expectancies are also reduced in the patient of glaucoma. But if the presenting visual acuity is good, then there is a useful longer life expectancy. Next is the inflammatory glaucoma. So what is the inflammatory glaucoma? Basically, due to the uveitis or any other inflammation of the iris, uh, it causes the obstruction of the trabecular meshwork, or it can do changes in the trabecular meshwork that leads to the glaucoma formation. Introduction overview. The elevation of the eyes IOP secondary to intraocular inflammation frequently present a diagnostic and therapeutic challenge. The elevation of IOP may be transient or innocuous, or persistent and severely damaging. So it can be just for a short period of time and not very much damaging, or it can be very persistent and severely damaged. The prevalence of the secondary glaucoma increases with chronicity and the severity of the disease. Secondary glaucoma is particularly common in the Fuchs uveitis syndrome and a chronic anterior uveitis associated with juvenile idiopathic arthritis. Posterior uveitis is less likely to affect the aqueous outflow pathway and consequently less likely to lead to IOP elevation. So basically, anterior side uveitis causes more of the inflammatory glaucoma. Diagnostic dilemmas. Assessment of the glaucomatous damage may be hampered by the small pupil or opacities in the media. So you cannot assess the fundus as readily as in other cases, because the uveitis is causing the view obstruction of the retina. Poor visual acuity may also compromise accurate perimetry IOP fluctuation. IOP fluctuation may be dramatic in uveitic glaucoma, and phasing may be helpful in patient with borderline IOP. Ciliary body shutdown caused by the acute exacerbation of the chronic interior uveitis is frequently associated with lowering of the IOP that may mask the underlying tendency to glaucoma. Even eyes with considerably elevated IOP 30 to 35 millimeter mercury may become hypotenuse during acute exacerbation of uveitis. Return of the ciliary body function with subsidence of the uveitis may be associated with the rise of an IOP in the presence of a permanently compromised outflow facility. Basically, the writer is trying to say that there are two mechanisms, because it is particularly challenging glaucoma. Why? Because the IOP tends to fluctuate a lot in a case of a uveitic patient. Why? Because the ciliary body gets shut down, means that it is not producing enough of the aqueous humor due to inflammation and changes in it, and it will cause the hypotony. So a uveitic patient may get increase IOP stages and decrease IOP, so there is a lot of fluctuation going on. So especially for that's why reason the treatment is very challenging, because and you have to do phasing in the case of a inflammatory glaucoma. So like eyes with, if you presenting IOP is like 30 to 35, then a patient may suddenly become hypotenuse as well. So topical steroid when used intermittently can cause a fluctuating IOP, because topical steroids are basically are used to treat the inflammation, and the steroids are also known to cause the um, raised IOP as well. Iris vessels may give rise to a diagnostic confusion with neovascular glaucoma. So how does it cause the um, uh, glaucoma? So there is an angle closure glaucoma with the pupillary block. Why? You know that whenever there is a uveitis and there is an inflammation, it causes the uh, pupil block. Why? Because there is a posterior synapses that form between the iris and the capsule. It will not allow the aqueous humor to pass from the posterior to the anterior side. So that is why will be the bowing of the iris peripheral, and it will cause the glaucoma formation. So one mechanism of the glaucoma is this angle closure glaucoma with pupillary block. So pathogenesis secondary angle closure is caused by the posterior synapse extending for 360-degree, which is known as seclusive pupillae, which obstruct the aqueous flow from the posterior into the anterior chamber. The resultant increased pressure in the posterior chamber produces interior bowing of the peripheral iris bombe, resulting in the shallowing of the anterior chamber and opposition of the iris to the trabeculum and peripheral cornea. Such an inflamed iris easily sticks to the trabeculum, and iridocorneal contact may become permanent with the development of PAS. Diagnosis: slit lamp biomicroscopy shows occlusive pupillae, iris bombe, and a shallow anterior chamber. Gonioscopy show angle closure with iridotrabecular contact. Indentation may be used to assess the extent of appositional as opposed to cynical angle closure. So this is the secondary angle closure with pupillary block. A is showing the seclusive pupillae. B is showing the iris bombe formation. This is the iris bomb that has been formed, and C is showing the iridocorneal contact. Next is the angle closure without a pupillary block. Basically, in this block, the trabecular meshwork has been obstructed by the inflammatory materials. So in this, there is an angle closure, and there is a um, uh, angle closure is basically due to the trabecular meshwork. There will be the peripheral anterior synapses that have been formed, and it is causing the obstruction outflow. So angle closure glaucoma without pupillary block. Pathogenesis: chronic interior uveitis causes the deposition of the inflammatory cell and debris in the angle. Subsequent organization and contraction pull the peripheral iris over the trabeculum, causing gradual and progressive cynical angle closure and eventual elevation of the IOP. The eye with pre-existing narrow angle may be at high risk. The anterior chamber is deep, but gonioscopy show extensive angle closure by peripheral and anterior synapse. So basically, in this case, there will be the peripheral anterior synapse, because when there is a lot of inflammation going on at the angle and there is an adhesion and peripheral anterior synovial formation, there will be the angle closure, but the pupil will still be normal. So what is an open angle glaucoma in the case of inflammatory glaucoma? In acute anterior uveitis, the IOP is usually normal or subnormal due to concomitant ciliary shutdown. So there is an ongoing ciliary body shutdown as well, so there can be the normal IOP or subnormal. Occasionally, however, secondary open angle glaucoma develop due to obstruction of the aqueous outflow, most commonly as acute inflammation is subsiding and ciliary body function is returning. This effect, which is transient and innocuous, may be steroid induced or caused by a combination of the following mechanism. So there are three mechanisms that has been uh, postulated in a case of an open angle glaucoma in a uveitis. One is that the trabecular meshwork has been clogged up by the inflammatory cells. Second is that there is a trabecular meshwork is itself becoming inflamed and causing an obstruction, which is a trabeculitis. And the third is that a steroid, topical steroid that patient is using in a case of a uveitis for the long term is getting causing the glaucoma. So trabecular obstruction by inflammatory cells and debris, which may be associated with increased aqueous viscosity due to the leakage of protein from the inflamed iris blood vessels. Acute trabeculitis involving inflammation and edema of the trabecular meshwork with secondary diminution of the intertrabecular porosity may result in reduction of the outflow facility. Is the thought that this is especially relevant in anterior uveitis associated with herpes zoster, herpes simplex, and other viral anterior uveitis and toxoplasma retinitis. So basically, most likely it occurs in a case of a viral uveitis. In a chronic anterior uveitis, the main mechanism for reduced outflow facility is thought to be trabecular scarring. So in this case, the trabeculum itself becomes scarred and or sclerosis secondary to the chronic trabeculitis. The importance of this mechanism is, however, difficult to determine, as most eye also have some degree of cynical angle closure. Because of the variable appearance of angle on gonioscopy, definitive diagnosis of the trabecular damage is difficult. In some eyes, a gelatinous exudate is seen on trabeculum. So, in a case of a gonioscopy, we can see sometimes a gelatinous exudate, but sometimes it is difficult to distinguish. So, it is a secondary angle closure glaucoma without pupillary block. A is showing deposition of the inflammatory cells in the angle. B is showing C is showing the cynical angle closure. You can see that there is a peripheral anterior synechies. So how will you treat a case of glaucoma? Medical treatment, medical control of IOP is more likely to be achieved if angle is completely open. The target IOP is usually lower in the eyes with advanced glaucomatous optic neuropathy. Long-acting depot steroid preparation should not be used in a known or suspected case of steroid responder. The effect of ocular hypotensive drug is but less predictable in uveitis. For example, same cases. So basically, the writer is trying to say that sometimes the glaucoma treatment is challenging because sometimes the steroid responsiveness is basically a very factor, and you have to know that how to control the inflammation and glaucoma at the same time if the patient is a steroid responder. And you have to keep in mind that certain ocular hypotensive drug is also very less predictable. Why? Because there can be ciliary body shutdown that is occurring. So these types of drug are also very unpredictable, like carbonic anhydrase inhibitor. A beta blocker is usually the drug of first choice. Prostaglandin derivatives should be avoided if possible, as they may promote inflammation and macular edema. The choice of additional agent often depend on the IOP level. If this is very high, oral acetazolamide may be required. For moderate elevation, less than 35 mm mercury on beta blocker in the absence of a significant glaucomatous damage, an alpha adrenergic agonist or a topical carbonic anhydrase inhibitor may be adequate. So if just first line of agent of treatment is beta blocker, if still the IOP is very high, then oral acetazolamide may be required. But if there is a moderate elevation, like less than 35 mm, we can give alpha adrenergic agonist or carbonic anhydrase inhibitor. Myotics are contraindicated as they increases the vascular permeability and as meiosis promotes the formation of the posterior synapse. Laser iridotomy. Laser iridotomy is performed to establish communication between the posterior and anterior chamber in eyes with a pupillary block angle closure glaucoma. So, laser iridotomy will only be helpful when there is an in a case of inflammation, there is a angle closure glaucoma with the pupillary block. Because of the iris bombe, when you make an iridotomy, the aqueous will flow from posterior to the anterior chamber. An iridotomy is likely to become occluded in the presence of active uveitis, and intensive topical steroid should be used following the laser. Correction of the pupillary block alone may not control the IOP if there is a insufficient exposed functional angle. Though a patent iridotomy may retard progressive pars formation. Surgical iridectomy is the definitive method of preventing further pupillary block and may be required if the laser fails to maintain a viable iridotomy. So, what is the difference between iridotomy and iridectomy? Iridectomy is done through the surgical procedure. You take the AC paracentesis, you take the iris out and you make a hole in the iris, and this is how iridectomy is done. So, when the laser iridotomy fail, you can go for the surgical iridectomy. So, what are the surgery that can be done in a case of a inflammatory glaucoma? Preoperative preparation. So, first of all, you have to control the inflammation. Control of a chronic uveitis for a minimum of 3 months before the surgery is ideal. Preoperative topical steroid should be used not only as a prophylaxis against recurrent inflammation but also to reduce the conjunctival inflammatory cell population. In a patient with a particularly liable inflammatory disease, oral prednisolone should be considered 0.5 mg per kg per day. Immunosuppressive treatment has improved the prognosis in recent years. So, first of all, if you are planning for the surgery in a case of a uveitic or inflammatory glaucoma, first you have to make sure that a uveitis is under control for at least 3 months. The eye is being quiet. And if you have planned surgery, you can give preoperative topical steroids or even some oral steroids as well. Trabeculectomy with mitomycin C or the implantation of a long tube implant can be used in these circumstances. Combined cataract and glaucoma surgery is relatively contraindicated but may sometimes be performed in conjunction with the goniosyncytialis. Occasionally, cataract surgery alone can be appropriate. In most cases, cataract surgery should be deferred for at least 6 months after trabeculectomy. So, after combined surgery are not recommended because after the surgery there will be the incidence of the higher inflammation. So, you do it as a separate procedure. If you have to do the cataract surgery, you do it at least 6 months after the trabeculectomy. Post-operative hypotony is particularly risk as a delicate balance may exist between the reduced aqueous production and restricted outflow. This is particularly likely to occur if there has been pronounced reduction in IOP when acetazolamide is introduced. Following surgery, steroids are tapered more slowly than in the non-inflammatory glaucoma. Cyclodestructive procedures should be used in caution as they may exacerbate inflammation. Possible underlying ciliary body insufficiency also carries the risk of profound hypotony that may risk progress to the thysis bulbi. So, in this case, particularly cyclodestruction is not so effective. Why? Because the patient has a tendency to go into the ciliary body shutdown. So, if you further do the ciliary body ablation, there can be the risk of the thysis bulbi. Tip: inappropriate use of the topical steroid is a significant risk factor for the development of a raised IOP and glaucoma. So next is a Posner-Skolosman syndrome. Posner-Skolosman syndrome, glaucoma cyclitic crisis, is a rare condition characterized by recurrent attack of the unilateral accused raised IOP associated with mild anterior uveitis. So what is happening in this case is basically there is a uveitis, but the uveitis is very mild and there is a very high level of IOP, and it is usually recurrent and unilateral condition. The mechanism is speculated to be acute trabeculitis, and there is an evidence that infection, possibly cytomegalovirus or H. pylori, may play a role. So there are certain organisms that can cause the inflammation of the trabeculum like CMV or H. pylori has been postulated. Prostaglandins are thought to play a role, and particularly prostaglandin E2, where the aqueous levels positively correlate with IOP. The presence of HLA-BW54 haplotype has been implicated in some cases. Posner-Colosman syndrome typically affect young to middle-aged adults. Males are affected more frequently than females. So males are getting affected. Episodes are usually unilateral. So it is unilateral disease. Although 50% of the patient have the involvement of the other eye at different times. The interval between the attacks vary, but usually become longer with time. Patients should be followed even after attacks have completely subsided, because a significant proportion will develop chronic IOP elevation with the fellow eye also at risk. So, what is the diagnosis? An acute IOP rise in PDS and a demonstrable CMV or other viral interior uveitis can present in an almost identical manner. So how they're basically writer is trying to tell the differential diagnosis. If a patient come with a mild interior uveitis and there is a very raised IOP, basically PDS can present like this, CMV can present like this, and other viral interior uveitis can present like this in the same manner. The signs of the former may be atypical in older patient and those with the dark hydrides. Simple IOP vulnerability in POG, especially the juvenile variant, must also be distinguished. Presentation is with mild discomfort, halos around light. So this is basically due to the corneal edema that there can be the halos around light. There can be the slight blurring of the vision in one eye and sometimes redness. So what will the slit lamp biomicroscopy will show? The slit lamp biomicroscopy typically shows a few anterior chamber cells and one to several fine white central KPs. So mild uveitis. So few cells, interior chamber and fine KPs. Injection is likely to be absent or mild. Mild corneal epithelial edema is frequent. Mydriasis is common. Posterior synecdoche are not a feature. But IOP is typically raised to over 40, out of proportion to iritis severity, and untreated persist for hours to weeks. Elevation precede the inflammatory sign. Gonioscopy show an open angle without pass. Glaucomatous optic neuropathy is relatively uncommon in most cases. Reversible coupling has been described. Treatment. Topical steroids are used to control inflammation with aqueous suppressant to lower the IOP. Topical steroids should only be used when there is an active inflammation and should not be used prophylactically. Topical or oral non-steroidal anti-inflammatory agent may also be helpful. The benefit of antiviral treatment is unclear. So basically, inflammation for to control inflammation, steroids are used, and to lower the IOP, aqueous suppressants are being used. So that's it for the glaucoma part 9. See you in the next lecture series. Thank you.